Welcome everybody. We had a big turnout tonight and glad you're all here. Hope you can hear me and hope they got enough food. Want you to know we do this once a month. We cover different topics, so you guys are welcome back anytime. I'm going to talk a lot about hand surgery tonight and try to cover a lot of topics quickly and go through a wide range of things, and then hopefully that helps you, and then also be around for some questions afterwards, okay? So why do my hands hurt? So a little bit about myself first. My name's Andy Putman. From Atlanta originally, big sports fan, and unfortunately still trying to get over the Falcons' loss. It's been a tough week, but I'm sure there's some Patriots fans here. I don't know. Yeah. All right. So I went to Auburn University for undergrad, and then I married a Georgia Bulldog. And then wound up staying in Atlanta went to Medical College of Georgia for med school, and then wound up staying in Atlanta for my orthopedic surgery residency. And then spent a year in Indianapolis where I specifically focused on hand surgery at the Indiana Hand and Shoulder Center, which I'm fortunate to say is really one of the predominant forces in hand surgery, and got some great training there. So a couple of the topics we'll talk about tonight, and we'll go through these as quickly as I can, but as specifically as I can as well. So hand arthritis, really one of the most common things I see, and I'm sure some folks unfortunately have it out here, and it's just wear and tear on the hands. We use them with everything we do, obviously, and eventually that catches up to you. The more miles you put on the tires, eventually they're going to wear out. And so joints will deteriorate. And what that means is every joint has a cartilage surface, so a lining on the joint, and that's supposed to glide smoothly, and over time that surface wears out, and then as it rubs unevenly, it's very, very painful. The causes for this, for the most part, osteoarthritis is the most common reason. That's just your routine arthritis, wear and tear. But there's some other causes, things like rheumatoid arthritis, inflammatory arthritis. And then if you've had any old injury to the hands, especially the football players, folks like that, some of those old injuries can lead to arthritis at an earlier age as well. So arthritis type pain, I think we all know, it typically comes on as dull, achy type pain. It comes on slowly. There can be periods of time where it really hits you hard, and that can have an acute flare. One morning you wake up and it's just a lot more painful than you remember yesterday. And then the typical pain is stiffness in the morning, takes a little while for the joints to get going. The most common spots, and we'll go through some of the anatomy, are listed here. The CMC joint here at the base of the thumb, again, probably the most common type of arthritis that I see, but we'll go through some of the arthritis in the other knuckles as well. So pain at the base of the thumb, really typically hits women age 45 to 65, but it can affect anyone. Very common, you have trouble opening jars, gripping, shaking people's hands, and that can cause a significant amount of pain there at the base of the thumb. And people talk about a circle of pain extending from the thumb and just all the way up the forearm, and really can affect everything you do. Some of the early treatments that you want to try, certainly rest, heat, ice. There's a lot of braces out there that people can try for thumb arthritis. No particular brace has been proven to be better than the other. You just have to kind of pick one that fits your life and your hand the best. So it's trial and error on that. Anti-inflammatories can be helpful. So your Advil and Aleve. And heat and ice both, but you're going to hear this mentioned several times through the talk. Really, heat does a world of good for the hands, especially for arthritis. And then you can get into cortisone injections, which can be very helpful as well. And those can all be done in the office. And then if those measures aren't working and it affects your life enough, then we start talking about surgery. Surgery options for thumb arthritis. The classic the classic surgery is to take out a bone called the trapezium, which is circled in red. And then once that's taken out, there's several different options. Most hand surgeons around the world stick to a fairly basic procedure where we'll take a tendon from your forearm and move that down into the space. left by that bone that we've taken out. And that does wonderfully and has been tried and true for a long period of time. There are some other options. One option, especially in young workers, people like in their 20s, 30s, do a lot of work with their hands. Sometimes we'll consider fusing the joint. That's a notoriously hard operation, and so we try to stay away from that unless we really have to. There are some metal and plastic implants that are out there. The track record on those is not quite as good as some of the routine procedure there with the tendon, but in the future that may become more prevalent. And then some people are putting a scope in the joint, putting in cameras, cleaning it out, things like that. So some of the other knuckles that can really hurt, the MP joints or the MCP joints, the big knuckle in the hand, and then the PIP joint, the middle knuckle, are real common spots. And again, a familiar topic or a familiar refrain here as far as treatment. Certainly heat and ice can be helpful. Again, can't stress enough that warm soaks, especially in the morning, can really give you a good start to the day. Anti-inflammatories again, and then you work your way up the ladder. Cortisone injections can at least give you some temporary relief, and we can do those in the office. And then if those aren't helpful enough, again, you can consider surgery. Surgery options, a lot of people are surprised by this. I hear this at least a couple times a week when we mention that you can replace the knuckles. There's some metal and plastic implants that do very, very well. And again, only if you get to the point where the other measures aren't working, but that's definitely something we can offer you. And then depending on the patient, there's always different circumstances. Sometimes we'll actually fuse the knuckle, which you do lose some motion with that procedure. But the upside is it's very, very good about taking away pain, and sometimes that's the appropriate step to take. A real common spot for arthritis as well is at the very end knuckle called the DIP joint. And a lot of folks, if you start looking around at your hands, you'll see these characteristic nodules or humps on the top of the knuckle. So one of the things we see a lot with arthritis at the DIP joint at the end is what's called a mucus cyst. I'm sure some folks have had some. They're kind of a little bubble right over that joint. They're very, very common. It's basically a sign of underlying arthritis. What happens is the capsule around the joint begins to weaken, and then fluid will escape up from that joint up to the surface, and it'll form that cyst. And so that gives you a sign of some things that are going on underneath. That can lead to a nail deformity. So you'll see some stripes or some ridging in the nail. And sometimes it'll begin to leak, or it can become infected, and those can be very, very painful. If the mucus cyst is not symptomatic, if it's not bothering you, it's just there, it's very reasonable just to leave that alone. In fact, I would tell you to leave it alone. If it's becoming bothersome, or if it begins to leak, it becomes infected, if it causes a nail deformity, then our typical recommendation at that point is to go ahead and cut that out. Again, the characteristic nail deformity you'll see here is that stripe in the nail, that kind of ridge that runs the length of the nail. And at that point, we can do a little surgery just to cut that out. Sometimes the arthritis gets very severe and to the point, again, that you get these humps and nodules. And if that causes enough pain to really limit what you do and interfere with your activities, then at that point we'd say, okay, let's talk about an operation. The tried and true operation for this is what's called a DIP fusion. You put a little metal screw in the tip of the finger. Scares everybody, but they do wonderfully. A very reliable procedure. You do lose a little bit of motion, but the hand works very well. It just comes down in a slightly different fashion. Instead of being able to curl that particular finger all the way under, it just comes down kind of in that fashion. But still a very functional hand and a good trade for a lot less pain. So switching topics, and I'm sure some folks in here have this. This is very common as a trigger finger. It can be any finger. It's not just the pointer finger, the trigger finger that you think about with a gun. It causes a painful clicking in the finger. People will talk about their finger will get stuck and then it has to pop out. And very common in the morning. Tends to loosen up over the course of the day, and very, very painful when that happens. So unfortunately, it tends to affect women more than men. People with diabetes, thyroid conditions, pregnancy can be more prone to have these, but I will tell you, they just tend to show up in a lot of folks all the time. They're very, very common. The issue is a tendon problem. So it's the best picture I could find, but the tendon, right as it enters into the finger, right at the end of the palm, begins to get stuck. It's supposed to slide in a tunnel that runs the length of the finger, and the opening of that tunnel is right at the base of the finger, and it just becomes stuck. It won't slide through smoothly, and then it gets to clicking and becomes painful. As that happens, we can treat it a couple of different ways. It does tend to be a little bit of an overuse problem, so certainly if you can rest it, warm soaks, things of that nature, but most folks that have it, we jump to a cortisone injection pretty quickly. These can be tremendously helpful. About a 60-70% chance that we can cure it with a shot. Sometimes it does take 2. Unfortunately, we've found out that if it doesn't cure up after 2 shots, then a 3rd shot's typically not going to help you. But at that point, we do have a little 5-minute procedure to fix that. It's called a trigger finger release. The concept there is you're opening up that tunnel. So it's a small incision over that finger. Go in, take the scalpel and open that tunnel up, and now the tendon can slide freely. It won't get stuck. A couple of stitches to suture the hand, and then let you go home. The hand typically recovers very quickly, and a very high rate of success with that operation. So along that lines, but a little more broad topic, is just your tendinitis across the hand and the wrist. Again, related to overuse and a little bit too much activity, repetitive motion, especially with particular job activities, can lead to that. No matter where it's at, again, you've heard this before, so it can be relieved with rest, heat, anti-inflammatories, avoiding the things that make it hurt. And this is typically your hand saying, I need a break, a little bit of a time off, so to speak. One of the most common spots for tendinitis is Dequervain's tendinitis. Again, repetitive use. The really common folks that get this are going to be young mothers because of how they're holding a baby. It tends to set the tendons off. It's pain right along the thumb side of the wrist. The middle-aged women tend to get it. So you'll see when you're trying to grasp or hold an object, you'll really activate those tendons. They begin to become painful. You get some characteristic swelling right along the side of the wrist. You can visually see it. And then sometimes you can feel a popping or a clicking, a lot like a trigger finger, but it is a little bit different. You'll notice that the pain is in a different spot. And then sometimes you'll get just a real small BB-sized cyst that you can feel along that side of the wrist as well. So treatment again, a thumb spica brace is the classic brace you want to use, and here's a picture of that. It is a little bit bulky, but it wraps up around the thumb and can give your wrist a break. Certainly needs rest, anti-inflammatories, but we found that the combination of a shot and a brace is extremely successful. And typically, in my practice, I find we don't generally have to operate on this, so we can get it to heal with a brace and a shot pretty routinely. Excuse me, I'll back up. If we do have to operate, it's a similar concept to the trigger finger surgery. Small incision, outpatient procedure, go in, open up that tunnel, and then the tendons can just slide smoothly, send you home, and the hand typically recovers fairly quickly. So a broad topic that I'm going to talk about for a few minutes, end up on here, is numbness in the hands. This is really one of the crucial things that we see, and we want to get this right and make sure that we can help you. There's a lot of reasons why you can have numbness and tingling. The basic concept is a nerve is having an issue. We need to figure out if it's getting pinched, if it's sick, what the issue is, and that's where either myself, sometimes neurologists get involved, sometimes it's a spine surgeon, but whoever it is, try to get some help and try to get that to resolve. You really want to avoid sitting on numbness too long, because the longer you do, the higher chance that you have some irreversible nerve damage. So our job, again, is to try to figure out where the nerve is getting pinched, and then any other possible reasons for the nerve damage. And then once we decide where we think the problem is kind of guide you on making the best decision as far as test, treatment, operations, and so forth. So again, real crucial to try to diagnose this earlier. The earlier we get it, the better chance we can treat it non-operatively. And then even if we have to do an operation, the earlier we catch it, the better chance that we can prevent any irreversible or long-term damage. So some of the symptoms that we're going to ask you about, and this is really where the patient comes into play, and I'll admit it's incredibly difficult to figure out when your hand is going numb exactly some of these factors. But if you can pay attention to them, it really helps us figure out what's going on. Questions I'm going to routinely ask you: which fingers are the most affected? And we'll kind of explain why in a minute. Is it one or both hands? That can be crucial. Do you have numbness that goes along with that in the feet? Any pain that's starting in your neck, shooting down into your arms, that can give you some guidance that maybe it's a neck problem. And then what activities are you doing that make your hand go numb? People talk about being on the computer, hands on the steering wheel, hands on the cell phone, making the hand go numb, and that can kind of guide where we think the problem is. And then are your hands going numb at night? And we'll talk about why in a minute. So a little basic anatomy, I think a lot of you guys are familiar with this, but nerves start obviously in the brain, go down the spinal cord, and then as they leave the spinal cord, they either go out to the arms, or then as you get down into the pelvis, they go out into the legs. In the arms, which was obviously what I'm going to focus on, you have the brachial plexus, which is just a thick wad of nerves into the shoulder, and then as that gets into the arm, it begins to split up and spread into different nerves. And as those nerves go into their particular portions of the arm, they can lead to numbness in specific segments of the fingers and the hand and the arm. So the classic three nerves that we worry about are the median nerve, ulnar nerve, and radial nerve. And again, what causes numbness and tingling is typically compression on the nerve, and we'll go through that. I'm going to take a quick detour. I focus on the hand and the arm, obviously, and that's where my expertise is. But certainly sometimes the numbness and tingling can be caused from neck issues. That's a real common spot. And so that's going to be a spine doctor or a neurologist that can kind of help you with that. And then sometimes diabetes can be causing numbness and tingling, or something along the lines of diabetes, a metabolic problem or some sort of overall condition. And that's generally going to be your primary care physician that can really help you with that. And so our job is to try to figure out what are those issues. With diabetes, just to mention, the real common pattern of numbness is going to be both hands, both feet, real classic thing. And so we'll get back to the hand because that's what I care about the most. So the nerves, again, median nerve, ulnar nerve, and radial nerve that we'll cover. As they get into the hand, they split into different spots. The classic ones as far as numbness are going to be the median nerve, which affects the thumb, index finger, middle finger, and then a portion of the ring finger on the thumb side. And then the ulnar nerve affects the small finger or the pinky finger, and then it affects the ring finger on that side of the small finger. So the median nerve, carpal tunnel syndrome, which is really the most prevalent numbness and tingling that we see. There's a ligament here that you can see called the transverse carpal ligament, which right at the base of the palm just lays right across the median nerve. And that tends to pinch the nerve. When that nerve is pinched, it begins to fall asleep, and that's when we get these symptoms of carpal tunnel syndrome. Very common condition, again, affects women more than men. The most common reason to get it is what we call idiopathic. It just happens really for no known reason. There are some controversies about overuse, but I think most of us would say that when we're on the computer or doing a lot of work with our hands, knitting, crocheting, things like that, you do tend to sense that numbness and tingling. So I think there's some relationship there. The science is a little bit fuzzy. And then folks with pregnancy, or folks that are pregnant with diabetes, rheumatoid arthritis, things like that, are more prone to get carpal tunnel syndrome as well. Classic symptoms that I hear about are pain at night. So you wake up, your hand's numb, You want to shake it out to try to make it feel better. It takes a few minutes and eventually it comes back, but it's frustrating during that period. Or pain in the morning. You wake up and your hands feel swollen, numb. Again, try to shake them out. Real classic description of carpal tunnel syndrome. Hands talking on the phone, doing computer work, driving. A lot of familiar things there. The ways we can diagnose, and you can run some of these on yourself. A common test is to basically bend your hands in that fashion, what's called Phelan's test. And if you hold that, you're supposed to hold it for 60 seconds, which is a long time. And if that begins to cause numbness and tingling into those fingers affected by the median nerve, thumb, index, middle, and ring, if you do that for 60 seconds, you can do it either way. You can go kind of the prayer position, or as drawn in this picture, the other way. That basically puts pressure on the nerve, and then over the course of 30 to 60 seconds, will make the nerve unhappy and begin to cause numbness and tingling. An easier way to do that is just to take your thumb and just put it right in the middle of your wrist at the base of the hand, and you just hold that again for 30 to 60 seconds. If that causes numbness and tingling, then that can be a sign of carpal tunnel. Real bad carpal tunnel, you'll start to see the musculature on the base of the thumb and that real kind of fleshy portion of the thumb will begin to waste away, and that can be a sign that a nerve's really sick, and we get really worried at that point. And then a nerve test, EMG or a nerve conduction study that's run by different doctors. Those can be extremely helpful in trying to diagnose not just carpal tunnel syndrome, but any of these nerve problems. They can help us isolate where that nerve's getting pinched, and they can give us some idea of how badly the nerve is damaged. Those tests are not fun, but it's part of this game here is trying to figure out what we can do to help you. So one of the common things when you have carpal tunnel syndrome that we'll recommend right away is to wear a wrist brace at night. So when we sleep, we all sleep with our wrists kind of bent in a fetal position. And when that wrist is bent, the nerve's kinked, puts pressure on the nerve, makes that hand go to sleep. So if we can get that wrist straight at night, which a wrist brace can help with that, it takes a lot of that pressure off the nerve, and it can really help in the mild case of carpal tunnel syndrome. Other things you can do, real simple things, are when you're at work or at home, pay attention to what's making it go numb and try to stay away from those situations, especially on the computer. Try to set yourself up for success. Get the right ergonomics, the right keyboard. Try to have a position on the wrist where you're not constantly flexed or extended, bent. And that can help alleviate some of these early symptoms. There are medications, anti-inflammatories, your Advil, Motrin, Aleve, not really proven to be that helpful, but it's at least something to add to the mix as you're trying to get this to go away. Prednisone, which is a short course of steroids, can be really helpful, especially in an acute flare. If it really hits you for a couple of days, that can at least calm it down, and that's a pill. And then a cortisone injection is steroid that we inject right there. That can be incredibly powerful and is really our go-to as far as non-operative treatment. It's got about a 60-70% chance of making it go away. It sometimes does take 1 or 2 shots, just like a trigger finger. Again, a lot of the same issues that if it doesn't go away after 2 shots, typically that 3rd and 4th shot is just not going to get us to where we need to be. And that's when we start talking about operations. So when to consider surgery, especially severe cases, when you start to lose muscle in the hand, when we have a nerve test that says it's severe, when you're getting to the point that you have constant numbness, it just won't go away at all day long. Typically we'll wax and wane during the day, but if it's there 24 hours a day, then we start getting worried about it. And then when some of these non-operative treatments are not working, especially the shots, after 2 shots, there's a lot of times time to move on to an operation. The other thing to mention too is as we get older, our nerves don't recover as well. So unfortunately we do tend to move a little bit quicker into surgery. They just don't do as well with some of the non-operative treatments such as the shots. And we really need to catch it early before the nerve gets to a point that it just won't recover. So the surgery itself, very simple surgery. I'm sure either you or some of your friends have had it, but an outpatient procedure. It just takes several minutes. It can be done either just like going to the dentist, wide awake, where we numb it up, or we can put you off to kind of light sleep, which a lot of folks choose, and that just gives you some comfort. A very routine procedure that typically does very, very well. The concept is just to open up that ligament, again, that ligament that lays right across the nerve, make a small incision in the skin, open that ligament up, and now the nerve has more room. Makes the nerve happy, hopefully, over time. Makes that numbness, tingling go away. There are multiple ways to do this. I would say as long as it's done well, they'll all get you to where you want to be. There's open and endoscopic techniques, mini open. All of them work. They have their pluses and minuses for sure. Recovery for all those techniques is fairly quick. Sutures come out after 2 weeks. The hand really, you're able to do what you want to do, but I'll tell you it's generally a couple weeks before you really want to tolerate a lot of use or a lot of heavy loads. And then you can really go back to work or your activities as soon as you feel comfortable doing it. Just acknowledging that it typically takes a couple of weeks for the hand to really feel up for a lot of that stuff. So the other common nerve that we see with numbness and tingling in the arm is the ulnar nerve. So again, runs down right along the inside of the elbow. The funny bone nerve is what a lot of people call it. And that comes down into the ring and the pinky finger. So that particular nerve is responsible for a lot of the fine motor movements in the hand, controls a lot of the muscles, small muscles in the hand. And so if that nerve has issues, you really start to lose some of that ability to do things like putting your buttons on, some of the fine things you want to do. It also causes symptoms at night. Some of the other things you'll see is atrophy in a slightly different spot in this circle here, right along the side of the index finger, in between the index finger and the thumb. That muscle will start to waste away. So if you see that, we can pinpoint that particular nerve as having a problem. Again, weakness or clumsiness in the hand. Sometimes the fingers in a real severe case will begin to claw, and so the fingers will take this particular position, and that's a real problem. The spot it typically gets pinched is right on the inside of the elbow. It has a term called cubital tunnel, which is different than carpal tunnel. By far the most common spot to have ulnar nerve problems. Less common is the Guillen's canal, which is down by the wrist. That typically shows up in people on bicycles for a prolonged period of time. Your triathletes that are doing a lot of heavy training, too much time with that handlebar, it's called handlebar palsy, can lead to similar symptoms. So cubital tunnel syndrome happens at night. Again, we all sleep kind of with our elbows bent and our wrists bent. When the elbow's bent, it just kinks that nerve, puts a lot of pressure on the nerve, and will make the hand go to sleep. You'll also notice this when you're talking on the phone, when you're driving. The difference is that the numbness and tingling will go down to the ring and the small finger. Carpal tunnel's on the other side of the hand. So really pay attention to that. The non-operative treatment, we try to basically get the elbow straight as often as we can. So the easiest way to do that is during the day, just be mindful of your arm. Try to keep your arm straight when you can think about it. Set yourself up when you're on the computer that your arm's not bent. There are some pads and some braces out there. The braces at night can be a little aggravating to wear. A really cheap, simple, effective thing that I recommend to folks is to rig this little apparatus, rig this up with the towels. Basically wrap that around your arm, either take an ace wrap or some tape, some duct tape. Tape that so you can just slide your arm in. Once you have that, then you can't really bend your elbow up freely, and that'll keep your arm straight at night. Certainly aggravating to wear, but if it can prevent this situation, then it's something we got to do. If that's not effective, then a therapist can make a brace that keeps your arm in a comfortable position and can take some of that pressure off the nerve as well. So when to consider surgery, a lot of the same concepts. Any situation we feel is severe, you're starting to lose muscle in your hand, you have constant numbness, nerve test says it's severe, then we start working towards surgery. And when the other non-operative treatments haven't worked, at some point we have to move forward with that. There are several techniques to do this. The incision is generally small, except for a certain situation where I'll talk about in a minute. The concept is similar to carpal tunnel syndrome. We make a small incision over the nerve on the inside of the elbow, open that space up, and now the nerve has more room. You just got to allow nature to wake that nerve up over time. There's one variant on that, which I say is fairly rare. Most of the time, all we have to do is a small incision to release it. But if the nerve wants to sit more towards the front of the elbow, then we go ahead and build a pocket for it and allow it to sit there in that more comfortable position. When we build that pocket, what's called a transposition, where we move the nerve, which they show here at the bottom, we do have to splint the arm, so it does kind of delay your recovery and a little more headache, but sometimes that's necessary. I would say that's probably less than 5% of the time, but when you do have that, we have to splint the arm for a period of time. You do come out looking like this guy, though. That's the upside. So I'll give the ladies a minute to, so the basic concept is numbness and tingling. There can be a wide variety of reasons why it can happen. Those are the reasons I tend to focus on, but part of my job too is to keep in mind those other reasons. And if I start suspecting that's the case, then a guy like me is going to try to get you to the right doctor and make sure that we get taken care of appropriately. A good exam can be tremendously helpful on isolating where that nerve's having a problem, where it's getting pinched. And I'll go back, I would say the patient is a huge part of that, because any symptoms that you can describe and the more you can focus on the specifics of why your hand's going numb and how it's going numb can help us. And again, you start with those non-operative treatments, and then severe cases move forward to releasing the nerve and giving that nerve more room to breathe. So that kind of covers a lot of topics quickly. It's fairly complex with our hands. There's a lot of other issues in play that can be causing some problems with our hand. The main thing we can do with any of these situations and some of the symptoms or the conditions that I didn't even go into is really just trying to pay close attention to what problems you are having, mention that to us, and then we can examine and generally help you a lot with a lot of non-operative things, especially your anti-inflammatories, injections, braces, can make a world of difference through your day. And then the one thing I want to mention at the end, I want to give a plug to hand therapy. So my role as far as hand surgery is to try to diagnose and treat and operate and so forth. But if we wind up in an operating room or even some of the non-operative things, folks here at our office can be a tremendous help, or any hand therapy office. They do a world of good and can really make these surgeries successful. The two we have here, Sonia and Anna, they're fantastic. We're lucky to have a team here. One of the only setups in the area that I know of where we have kind of everything in one house: hand surgeon, hand therapy, so forth. And we can just walk down the hall and converse, and so that's been a real great addition to our practice. And just we recommend, no matter where you get treatment, that these hand therapists are incredible on the things they can do for you. So that concludes my talk. I'm glad to take any questions. I'll give a shameless plug to my family, but I know the grandparents like to see pictures of the kids. But